Trauma-informed care begins way before the patient reaches the provider. A true trauma-informed approach involves the whole environment and every member of the team.
At the front desk, we're all about setting the tone for a patient's experience. So before we open, we prep by making sure there's clear signage that creates a warm and welcoming atmosphere. When patients arrive, I make sure to make eye contact with them. Even if I'm on the phone, I motion to the patient that I see them and I will be with them in a moment. I know how awkward it can be coming into a strange setting like this. When I call them forward, I give them a friendly greeting and I offer as much privacy as I can. It's all about making patients feel heard and respected. I want the front desk to really set the stage for trauma-informed visits.
I always try to remember how important a first impression is. The tone for the whole visit is set from the moment they walk in the door. This might be silly, but it actually makes me feel really important. I try to remember, I don't know what stress people are coming in with. It could be anything from a new serious diagnosis to a really hard time finding a parking spot. I want them to come away from the check-in process a little more at ease than they were when they walked through the door.
I sometimes hear concerns from colleagues that trauma-informed practices take too long. I think it's important to remember that it's about quality, not necessarily quantity. Making a few meaningful changes matters, even if you can't change everything all at once. It's not about taking more time, it's about how that time is spent. For example, giving a patient the choice of telling you their information or passing you a photo ID to check in doesn't actually add a significant amount of time.
Before I even call a patient back, I review their chart. I take note of preferences that are documented, like what they'd like to be called. When we're meeting, my first goal is to create a comfortable atmosphere. I introduce myself with my name and my pronouns, giving them a chance to share theirs if they'd like. I match my pace to theirs as we're moving to the next area. When it's time to take vitals, I explain each step and give as many choices as I can. It's all about fostering communication, sharing control, and respecting their boundaries.
Sometimes in the medical field, we get into the habit of doing something because it's just what we think has always been done. Trauma-informed practices help us call those habits into question and let us assess if we really need to do them. Getting a patient's weight is a good example. Do we actually need that information to care for the patient today? And if we do, does the patient understand why? Are we able to wait until the patient sees the provider so we know if weighing a patient is necessary? In my office, when the nurse gets a patient's weight, they give the patient the choice on whether or not they want to hear or see the number. And even if the information is important to have, we make sure the patient understands that it's still their choice.
We ask patients to be vulnerable and share a lot of information with people who are likely to be complete strangers. Sometimes they have to share the same information multiple times. Before I leave a patient after intake is complete, I ask if there are any concerns they'd like me to prioritize with the provider before they start the visit. I always have to remind myself that while these questions are routine for us and something I ask many times a day, they are anything but normal and potentially very personal or hard for the patient. I make sure to repeat the name of the provider and let the patient know as much information as I can, like about how long the wait will be and that the provider will knock before entering. When I can, I talk with the provider before they enter the room and let them know the patient's preferred name, their pronouns, and any other information the patient has asked me to share.
The interactions that the patient has had with other staff before I ever meet them have hopefully helped the patient feel safe and empowered. I get to benefit from that, and I also really want to build on it. I make sure before I enter the room that I knock and I hear a clear answer to enter. When I meet them, I make sure to introduce myself, and I make sure that I'm using their correct name. And I'm also really mindful not to position myself between the door and the patient whenever it's possible, since feeling trapped can really be activating for many people. I sit down so I'm not towering over the patient. It's one simple and visual way to start leveling those power dynamics. I want to share control and power as much as I can in the visit with the patient. The provider's the expert in the field of medicine they practice, but the patient is really the expert of their own life. Really, they're allowing me to care for them. Before I begin any exam, I ask what questions a patient might have for me. Once we walk through those, I provide an overview of what the examination will be that I recommend. I let them know that they can ask questions or tell me to stop at any time, reinforcing that they're the ones in control. There are certain adjustments I've made based on my experience to support patients who have a trauma history, but these practices really benefit all patients regardless. For example, for a breast exam, patients may choose to keep their shirt and bra on and then lift those themselves for me or change into a gown. Another example is the thyroid exam. For many patients, for example, some who've experienced being strangled, having their neck or throat touched can really be activating, just as activating as having a pelvic or breast exam. So in addition to explaining the exam, I make sure to ask explicit permission to begin. I shift from the perspective of what a patient can do to make something easier for me to thinking about the patient's comfort and how I can adjust what I'm doing. When I prioritize the patient's comfort and sense of safety, it really doesn't adversely impact my ability to do an exam or provide care, and it doesn't take more time. Using stirrups is one example. Using stirrups can be physically uncomfortable for patients, and it can make them feel unsafe and out of control. Anytime I can, when I need to do an exam that typically calls for the use of stirrups or footrests, I give them choices. They can use the footrests, or they can place their feet on the extension at the bottom of the exam table, whatever's the most comfortable for them.
For providers, integrating trauma-informed practices is about a shift in approach and mindset. Trauma-informed care enhances the patient-provider relationship, communication, and overall patient experience, which can ultimately save time by preventing misunderstandings, reducing patient anxiety, and getting patient buy-in. Incorporating trauma-informed practices is about making small changes, like prioritizing clear communication, offering choices, and creating a welcoming environment. These adjustments often enhance patient care by reducing potential obstacles caused by unaddressed trauma triggers. By fostering trust, respect, and empowerment in our patients, we're creating a better atmosphere for accurate diagnosis, effective treatment, and improved patient outcomes. It's a win-win situation that benefits both patients and providers.